Hi, my name is Gabrielle Lujan, and I'm a graduate student in Eastern Kentucky University's Psychiatric Mental Health Nursing Practitioner program. I'm here today to present my project proposal for biofeedback as an adjunct treatment to substance use disorder. Substance use disorder is a huge problem in the United States. It's a public health crisis and a chronic health issue. 27.1 million people in the U.S. abused drugs in 2015, according to the U.S. Department of Health and Human Services. And it costs the United States over $400 billion annually in crime, healthcare costs, and loss of productivity. Overdose is now the leading cause of accidental death in the U.S., causing 47,055 deaths in 2014. Biofeedback is a non-invasive mind-body technique that teaches people to use their mind in order to control their body's involuntary biological responses and induces a relaxation response. It is an evidence-based treatment for things such as anxiety, stress disorders, pain, headache, GI problems, and many more. Many of these issues are experienced by people going through withdrawal symptoms during substance use disorder treatment. There's lots of supporting literature that backs biofeedback as an effective treatment for substance use disorder in addition to treatment as usual. Study 1 was Degani-Irani et al., 2013, a level 2 randomized control trial. Their treatment was biofeedback plus treatment as usual versus treatment as usual alone. The results showed significant improvement in psychological distress and craving severity. However, they had a very small sample size of 20 and no female participants. Study 2, Rostami and Degani-Irani, 2015, was also a level 2 randomized control trial. They used biofeedback plus treatment as usual compared to treatment as usual only. They also saw significant improvement in addiction severity, mental health, and quality of life for participants in the treatment group receiving biofeedback. However, they also did not have any female participants, which is limiting. Study 3, Eddy et al., 2014, is also a level 2 randomized control trial. Their treatment was biofeedback plus treatment as usual versus treatment as usual only. The results showed a medium effect size trend toward reduction in substance craving, however, it did not reach statistical significance. This is due to a very short treatment time, only 3.5 hours total over 28 days. In addition, they had a very small sample size and no female participants. Study 4, Hashemian, 2015, is a level 3 non-randomized controlled trial. Their treatment was real biofeedback compared to sham biofeedback. The results showed significant decrease in substance craving for the real biofeedback group. However, they also did not have any female participants. The objective of my project is to compare the effects of outpatient biofeedback plus treatment as usual compared to treatment as usual alone on addiction severity in male and female adults 18 to 25 over 12 weeks' time. The participants must be diagnosed with substance use disorder of a Schedule I or Schedule II substance, must be taking medications as prescribed for at least 12 weeks, abstinent from substances for 4 weeks, and no history of anoxia, head trauma, stroke, encephalitis, or HIV. The methods include recruitment. Gunderson Health System Outpatient Behavioral Health Clinic will be the site of both recruitment and treatment. Nurse practitioners will recruit voluntary participants during routine appointments, and they will be provided with an informational flyer and a verbal recruitment script. Treatment will take place over 12 weeks. The first week will be a 60-minute intake appointment where we will meet and greet the participants, and they will get to meet the investigator and the biofeedback trainer. They will go through informed consent, and they will be assessed with a pre-treatment addiction severity index as performed by the primary investigator. Then they will go through 12 weekly treatment sessions of biofeedback. Each treatment session lasts 45 minutes. 15 minutes is allotted for the hooking up and unhooking of equipment, and 30 minutes will be specifically for the biofeedback training. Scheduled appointments are made at participants' convenience Monday through Fridays at the outpatient facility, 8 a.m. to 7 p.m., and there will be a limited amount of bus tokens available for participants who do not have transportation. At the end of the 12-week treatments, there will be a 60-minute exit appointment as well, where a post-treatment addiction severity index assessment will be performed. Then data analysis will be performed for 4 weeks, and a presentation will be prepared. The addiction severity index is my outcome measurement for my treatment. So the outcome measure is addiction severity, as measured by the Addiction Severity Index, which is a comprehensive semi-structured interview, has 7 subscales measuring medical status, employment status, drug and alcohol use, legal status, family and social status, and mental health status. It is the most widely used standardized substance use disorder measurement instrument in the world and has very high levels of validity and reliability in numerous studies. The pre-treatment and post-treatment scores will be compared and analyzed with SPSS through a multivariate analysis of covariance, and also known as a MANCOVA. For dissemination, it will take place over 12 weeks. A PowerPoint presentation will be presented to stakeholders at the outpatient clinic, and then a poster presentation will be put on display at the clinic as well for other patients and anyone who comes and goes. It will be put up for 12 weeks. In addition, if there are significant results, they will be forwarded to all Gunderson Health System outpatient providers. This project hopes to aim to fill in the gaps. So we hope to establish lots of female participant data, extend the treatment time, and have very specific inclusion and exclusion criteria. The literature suggests that biofeedback is a low-risk treatment with very high potential benefits for people already in substance use disorder treatment, and it's easily integrated into an established outpatient treatment program. The hope is that biofeedback can increase access to evidence-based treatment and increase the number of people who receive treatment and then move them toward recovery to improve the health status and quality of life for all. I would like to take this time to say a special thank you to Dr. Heather Norris for your ongoing guidance and support, and to the Gunderson Health Systems and Ann Gisvald, Christine Brink, and Jean Kolakowski for their support and assistance in making this project possible. Thank you.